So it's my great pleasure to be here this morning to chair this session on global oncology policy perspectives. And over the next hour, we'll explore what a career path in global health can look like through the perspectives of those working within professional societies, within non-governmental organizations, and within the UN. So we have a diverse panel this morning. Some of you can see on the screen here, and some who are sitting in the front row. And I'll introduce everyone as their turn comes up to speak. And each of our presenters were asked to prepare a few slides that address the following three questions. The first was on how he or she was engaged in health policy or cancer program development. The second was to describe what they perceive to be as the biggest challenges and opportunities within their field of work. And the third was targeted to many of the young investigators in the audience. We asked each of the panelists if they could do things differently if they were starting out today, how might they change things? So I will have each of the speakers come up, and then we'll have time for dialogue and questions at the end. So I would encourage the audience to think through your questions and things you would like to ask of this panel as we go. So I'd like to start by calling up Dr. Nkozo Ndlovu. Dr. Ndlovu is a radiation oncologist, a senior lecturer, and a departmental chair at the University of Zimbabwe College of Health Sciences. She's the head of the Division of Radiotherapy and Oncology at the forgive my pronunciation, Peri-Renyatwa Group of Hospitals in Harare, Zimbabwe, which is a cancer treatment center that's serving most of the country. Dr. Ndlovu has been involved in human resource capacity building at a local and at a regional level, coordinating a master's degree program, developing collaborative research partnerships, and through leadership roles within the International Atomic Energy Agency, the Radiation Protection Authority of Zimbabwe, and the African Organization for Research and Training in Cancer. So thank you very much.
Thank you very much, and good morning to you all. Right, where do I advance this? Thank you. Okay. So I was asked to answer three not so easy questions in 5 minutes. So let's see how I'm going to do, if I can advance the slide. The green, this one. Oh, this one. Okay. It's the screen button right there. It's not doing anything.
Let's try it again here. There we go.
My 5 minutes will be over very soon. So the first question, how am I engaged in health policy and cancer program development? I've been, over time, been involved in a number of things that I've come across, such as the development of our national cancer prevention and control strategy, development of treatment guidelines locally and regionally, and cancer treatment equipment, infrastructure development, where we were refurbishing our centers. We have 2 centers in Zimbabwe, so we're refurbishing them to get modern equipment. And from time to time, I get involved with deciding on cancer drug procurement priorities, what is needed, and because unfortunately we don't have an open plate, where everything is available, but sometimes we have to prioritize and say what fits with the budget that we have at the time. And then, of course, the human resource and curriculum development as an academic at our university. What have been the biggest challenges and opportunities that I've observed in this space? I just took 2 challenges and 2 opportunities because there are quite many to cover in such a short time. And the summary of, I tried to summarize them, 2 points. awareness of cancer as a priority in the region where I come from. Cancer is not a priority most of the time. Hopefully, this is going to change, and we're seeing the changes coming on slowly. But there's prioritization of HIV and AIDS, vaccination for children, maternal and child health. By the time we come to cancer, everyone is just exhausted and they don't want to hear. So it makes it that much more difficult to then knock on those doors and make people listen, even just to what you have to say. And then the other big challenge is that of resources. Whichever way you look at the resources, be they human, financial, infrastructural, it's just, depletion of resources, non-existent resources most of the time, and we have to work within that environment of making the best what we can with the little that we have. And the opportunities, I try to sum them up again and into two. One that I thought I would talk about is, the approach of things from a technical point of view. It seemed to be a hindrance at first, but considering that cancer is not a priority, if you go there and you have to convince the leadership, you have to convince the policy drivers, as an academic, as a clinician, it becomes very difficult to actually put yourself across the way that they think. But sticking to your technical point of view, the viewpoint of things from that technical stand, and so that you don't get entangled in political discussion. And you stand by that, if this is what the people need. Cancer has got to be treated. We need equipment, we need drugs. These are the statistics. This is how we do it. This is what we've been trained to do, and we are here to do it this way. That has sort of like broken barriers. And sometimes it takes a while to actually get there. But in most of this, sometimes you get sent away. But when you get listened to, when you're taking that stand, sometimes things do happen. And then, of course, collaborative partnerships with local and international organizations. That's how we have advanced even issues of how to improve our treatment facilities. For instance, we worked with the International Atomic Energy Agency. We just had to be guided on procurement processes for linear accelerators because we did not have that capability. Being radiation oncology is a relatively new specialty where I come from. Surgery has been there for years, pediatrics has been there for years, but radiation oncology was a fledgling specialty. So getting to have those partnerships that do that all the way up to research partnerships, so expertise in all the aspects, and then of course team building, which goes very closely with that, building up our own local team and strengthening it. And then how might I do things differently if I were starting out today? I said, I sort of looked, for this question, I looked up in the sky. I didn't know what to answer. But then I found that actually realizing that it does not entirely depend upon me, and I should be kinder to myself. I think when I was younger and I had more energy, I really would push and, almost cry and go home, distressed that things are not working out. But now I'm beginning to realize that, okay, fine, I have to forgive myself and say, I'll do what I can and have time, for me as well. You know, that picture is actually a picture of one of our golf courses in Zimbabwe. You can see the bunker there. You can see the whole, what's called the green. You can see I don't play golf. And that's why I put that picture there, because when I thought, you know, I should have actually taken time to play golf. I know I'm giving myself excuses and saying, oh, it takes too long, and you know, that little ball is too hard to strike anyway. And that is why animals end up going to graze on the golf course, because we're all busy doing things. So as you know, wild animals don't go near where people are. So that golf course was not being used enough. Thank you.
Okay, great. Thank you very much. It's a good photo to end on. I will just take a moment. Does anyone have any specific questions for Dr. Ndlovu that they would like to ask at this point? No, we'll save them for the end? Okay. So I'd now like to turn our attention to one of our teleconference participants, Dr. Yolanda Levens, who was unable to make the conference today due to a general union strike in Belgium that left all of the planes grounded, but she's here with us via teleconference. Dr. Levens is a radiation oncologist, a health services researcher, and chair of the Department of Radiation Oncology at Ghent University Hospital in Belgium. Dr. Levens has collaborated with various international organizations and institutes and is the immediate past president of the European Society of Radiation Oncology, ESTRO, and the Belgian College for Physicians in Radiation Oncology. Currently, she is co-chair of the ESTRO Health Economics and Radiation Oncology Project and the chair of the ESTRO Global Impact of Radiotherapy in Oncology Project. Yolanda.
Thank you so much. I hope you can hear me. Yes. So good morning to all of you. Yeah, it's really a shame that I couldn't make it. Thank you very much for the invitation, but indeed the unions in Belgium decided differently about my traveling. But I hope I can make up a little bit by discussing with you in a short presentation the way in which ESTRO has been tackling the global oncology policy perspective, and I will really mostly focus on Europe because that's really the key context of ESTRO. Now, you should probably realize that ESTRO is, by definition, a scientific organization. A scientific organization that also focuses a lot on education, and policy has never been in its genes, actually. But that doesn't mean that at some point the board started to think about, well, we need to generate evidence to allow our members and our national societies to endorse better radiotherapy. And they needed evidence on needs of radiotherapy, on availability, on cost effectiveness. And that's how the HERO project was launched in 2010. And you can see a few of the data that we've been generating. We have here, for example, data on availability, different resources across Europe with different heat maps. You see there's a large variability. If we look at the utilization of radiotherapy in Europe, where we think that, well, it should be more or less optimal, well, the green line is the optimal, and you see that for different countries, there's still an enormous gap. And then we also predicted the needs into the future, and we calculated that on average in a decade, we would need about 16% more radiotherapy courses in Europe. So there's quite a challenge. And we've been devoting quite some time lately to populate a cost calculation model that we've been developing, where we are working together with the national societies. Now, these kind of data have been used, well, they have been published first, but then they've been used to develop an advocacy toolkit for national societies in which we have been defining clear messages that they could use to, well, show the benchmarking of their country and discuss that with their governments to position radiotherapy better in the country. We've also been developing a public affairs flyer, which we have been using more specifically to communicate with other stakeholders, amongst other policymakers. While I was president, in the 2 years I was president, we had about 10 face-to-face meetings with EU decision makers, where we were trying to really build a community of ambassadors at European level to forge strategic partnerships. And it actually translated in a few policy fora that we have been able to do at European level, one at the end of 2017 with the launch of the Marie Curie Legacy program, and then one just a few weeks ago where we discussed the white paper that we have been launching end of 2018. Now, what we actually do is really trying to elaborate on data from countries, benchmark it and collate it to the European level, and then bring it back to the European countries so that they can use it to have this discussion with policymakers. And for example, with the Marie Curie Legacy campaign, we really try to tackle the perception barriers, increase the knowledge on radiotherapy and raise awareness about the value of radiotherapy, and reassuring people also that it's a safe and very optimal part of the multidisciplinary oncology. And we try to develop messages that are really focused on different stakeholders, healthcare professionals, decision makers, and civil society. And what is also probably quite important at European level is that we try to develop the messages through the national society so that we tackle really the needs at a specific country, and we have a whole group of national champions that help us to make these campaigns at national level, which are very often targeted or linked to an event on radiotherapy that is going on in the country. And at the bottom you just see a few YouTube links where you could see if you have time later on, a few of the movies that we developed for the Marie Curie Legacy campaign. Then if you take it down to the national level, I can just give you a short example of what we've been doing in Belgium, because actually when the governmental bodies understood what we were doing at European level, they asked us to develop a similar program for Belgium and to develop a discourse on resource planning, which was actually in the context of a broader hospital reorganization report. We have also been working very closely together with the Belgian Cancer Registry, the HDA organization, the reimbursement parties, in order to define better access and reimbursement. And I think close collaboration is really key in that perspective. And Danielle already mentioned that we are very happy at ESTRO that we have been asked to take over the lead after the great project of the Global Task Force, and to try to turn knowledge into action at global level as well. And we continue to collaborate with the key stakeholders within the project, within the Global Task Force at the time. But of course, we try as much to collaborate with a very broad group of people in order to make the tagline that you see at the bottom of the line, saving 1 million lives by 2035, which was really a key message from the Global Task Force to try to get into action. So if you then ask me, what are challenges and opportunities? Well, I've actually linked them together because I think challenges make opportunities. And I said that originally the DNA of ESTRO was not really into policy making, it was really science and education. But with this HERO project, we have been able to broaden the portfolio of services to our members, which is very important, I think, and to really embed policy in the governance structure of the society. It takes time to know with whom you have to discuss, and in different countries this may be completely different. You have different key stakeholders, but discussing, interacting, collaborating is extremely important, and try to tune your messages really to those who you want to give your message to. Then I showed you that Europe is a variable landscape, and then therefore one message does not really fit all. It's not always the same way you have to give your message in the different countries, and therefore we engage so closely with the national societies in order to understand better the country specificities. Now, there may be many initiatives, and there are an enormous amount of initiatives, but we, I think, still lack some kind of coordination, definitely at European level, but also at global level. And I think that this is an important message to take. We should all link our efforts and try to collaborate as much as possible and join forces so that we all go into the same direction, because we, at the end, all have the same goal. I have actually not put a slide on what I would do differently, because I think that I rolled into this from my very early career. I did my PhD on cost and cost effectiveness at the moment where people were still thinking this was not something a doctor should do. But I think over the years it turned out very nice that it was picked up more and more broadly, and that I can really do something that really matters to the patients at the end. And I would like to end my presentation with the words of Marie Curie, who said that we must have perseverance and above all believe in ourselves. Thank you for your attention.
Okay. Thank you, Dr. Levens. So next up, I would like to call Dr. Joel Yarney, Dr. Yarney is a consultant oncologist and director of the National Center for Radiotherapy Oncology and Nuclear Medicine at Korle-Bu Teaching Hospital in Ghana. I probably said that incorrectly. He was chair of the committee that developed the cancer control strategy for Ghana, oversaw the implementation of upgraded radiotherapy and nuclear medicine facilities in the country, including the introduction of prostate seed brachytherapy for prostate cancer 5 years ago, and worked with the Ministry of Health to develop a population-based cancer registry. He has also worked as a consultant for the World Bank, the IAEA, and continues to chair cancer treatment guideline committees in Ghana, and was also notably formerly a fellow at Princess Margaret Cancer Centre in Toronto. Dr. Yarney.
Can I have my presentation, please? Yeah. So thank you for the kind words. Oops. Howdy. Yeah. I'd like to illustrate and answer some of the questions using Ghana, you know. And this is the population of Ghana, now currently about 30 million. The disease profile is changing over time. Currently, about 43% of cause of death is due to non-communicable diseases. And about 10, 15 years ago, it was much lower. So it's changing rapidly. But then cancer forms about 5% of all deaths. So I can readily identify with what the Ontokozo said, that sometimes it's difficult to convince public health officials that cancer is a problem, but it's changing over time. I'm sure most of us are familiar with this. So we are somewhere there. We continue to have a high birth rate. Death rate is decreasing, but not rapidly. So we are in demographic transition. So we think that the burden of cancer will increase over time, particularly due to increase in life expectancy. It's changing rapidly over time. Now it's in the 67, around 67. Meanwhile, 10 years ago, it was in the 50s. So life expectancy is increasing. And with that, we know that incidence of cancer is going to increase. And if you take a look at the gradient is steeper for less developed countries relative to Western countries. Let me see. It's less steep. It's almost flat for the Western world, but in the low middle income countries, the rate of rise in the incidence of cancer is increasing. This is a paper we published with assistance from IAEA. I took a portion of it to illustrate the quality of data we have with cancer. GlobalCan 2012 published the quality of data. And the quality of data for Ghana, for instance, was F. F doesn't mean failure, by the way, but it's frequency data. So the quality of data, and therefore the incidence of cancer, I think it's most from GlobalCan, it's mostly by extrapolation. I have a feeling that the problem is much bigger than we report. I've been involved in National Strategy for Cancer Control. I chair the editorial committee, trying to formulate policy for Ghana. And during the preparation of this slide, we looked at the civil registration coverage of cause of death. And it's pretty obvious that for most parts of Africa, there isn't much data on the cause of death. Again, you take a look at the radiotherapy machines across the world. In Western Europe and America, the number of radiotherapy machines per million people is 5 and above, compared to most parts of Africa where it's less than 1. So it's a big problem. The number of radiotherapy machines is really a big problem. Even where there are machines, the utilization is very poor. Look at Ghana, optimum utilization of radiotherapy. This paper was published in the Green Journal, by the way, but about 51% of cancer patients should benefit from radiotherapy. But in practice, it's just about 9%. There's a big gap between 51 and 9 for various reasons. You see in Ghana, we have 3 centers, 2 in the capital city, 1 in Kumasi. So if a patient is somewhere here, it will take a long time for them to get here. You know that radiotherapy protocols cover 6 weeks, 7 weeks. Patients have to stay away from their families. So this makes utilization very, very, very poor. This is a study yet to be published. It's depicting the distance patients have to travel in order to get to the treatment facility. And in Kolebu, Accra, where I live as a capital, patients have to cover a distance of about 43 kilometers averagely to get to treatment centers. And this is patients who have reported. I think that if you take into consideration the whole country, the patients who have to travel all the way from where they are domiciled to Accra, I'm sure to be in the hundreds and 200s. Because I think that they are in the majority, considering that the utilization rate is just about 9%. It means most patients are not coming at all. Other considerations, patients have to pay out of pocket. So we are analyzing the barriers to care. Patients have to pay out of pockets, and like for biopsy, chemistry, imaging, surgery, these are the percentages, and a lot of patients cannot afford. So distance and then affordability are issues. Patients, between patients, the time that patients first notice the symptoms and when they report. A study done by some of my colleagues reported between 3 days and five years. So these are the issues that we have to grapple with. As a result, Horia is somewhere there. This is a paper that we published. I just put this in to illustrate a point about the burden. This is about cervical cancer. KM curves, you can see the proportion of stage 2, stage 3, stage 4 diseases. It's quite high. So we have late presentation, poor utilization, and not an accurate determination of the burden of cancer. These are issues that most parts of Africa have to grapple with. So this is what engages us. If we have a holistic approach to determining how best we should solve the problem. First, we need to determine the size of the problem. So civil registration needs to be improved. Cancer registries, which I'm involved in, needs to be improved. We need to, if we concentrate too much on treatment, late presentation, no matter how well your treatment programs are, you are not going to succeed at curing them. So the approach should be from prevention, cancer control continuum, from prevention to palliation, public education, screening so that you can have detect early disease, do research. We have to establish new centers, recognizing that when radiotherapy centers are established, the other services usually also congregate around them. Surgery, medical oncology, where there are centers. That's the observation in Africa, most parts of Africa. You'd have them developing around them. So we need to establish new centers to make sure that the geographical distribution and therefore geographical access to treatment is improved. And with that, you need manpower, so education and training, access to financial barriers to care need to be improved. And we can achieve all that through good advocacy and relations with government to ensure that there's early recognition of symptoms and presentation, early disease, and then good treatment for them. Thank you.
Thank you, Dr. Yarni. Next, I'd like to go back to one of our teleconference participants, and I'd like to ask Dr. Kirsten Hopkins to be our next speaker. Just wait for the teleconference participants to appear on the screen. Great. Dr. Hopkins is at the International Atomic Energy Agency, but she is originally a clinical oncologist from Bristol, UK, and during her 16 years in practice there, led the neuro-oncology service, developed a stereotactic radiation program and community chemotherapy delivery service, and was a training program director for clinical oncology trainees. Dr. Hopkins now works as an advisor or a technical officer, I should say, at the International Atomic Energy Agency, where she provides advice and support to countries developing and expanding their radiotherapy services. Dr. Hopkins.
Thank you very much. Thanks, Danielle. And it's a great pleasure to have been invited. And I would just like to express my displeasure that I'm not with you in person. Unfortunately, that was a clash happened, and it's partly because I'm due to be in Kigali next week. And the greatest irony is that I'm booked to go to Kigali with SN Brussels. So I'm just waiting to hear that actually that's going to be cancelled too. Okay, can you just confirm? Can you hear me?
Yes, we can hear you.
Great, thank you. Okay, so Danielle was very specific. I initially thought I should be talking about IAEA, but she said, well, partly how are you involved, but also what do I think are the greatest challenges and how might I do things differently in my career in global work if I started out again. But in terms of in terms of what I'm doing now, I have a very pleasant job and I get to engage with people like Ntokozo and Joel Yarni very frequently. So I'm primarily here as a radiation oncologist, although I'm clinical oncologist by training. And in the agency, we advise the IAEA technical cooperation projects, which are really partnership projects between the TC department of the agency and their member states in any branch of nuclear technology. But of course, I'm only get involved to advise if it's a project related to radiotherapy. And that can be more or less anything. There can be a country that wants to develop its first radiotherapy center ever and really doesn't know a lot about it, even up at ministry level. Or there may be people with existing services where they want to expand services or introduce more advanced radiotherapy techniques or start some local training schemes, which is always really important. And when they propose those, the TC staff will come to my boss and say, can you allocate an oncologist to us to advise us as to the robustness of this project and what kind of activities might be involved within it. I knew a little bit about that before I came. I didn't actually know at all that we also coordinate and run clinical research protocols in our member states, in the departments. And that's because we know that care is improved by people being involved in research and clinical trials. And also there's a huge resource in low and middle income countries. There are a lot of patients having treatment for cancer. But it's very difficult to get started. It's difficult to break in and be in the commercial studies or even the big organization studies. So we involve CSIs, as we call them, chief scientific investigators from the member states, bring them together and design a project together. There's a little bit of money with it. It's not very much at all. Most people have to almost support themselves, but a little bit. And largely, we're everything from coordinator, so sponsor in the trial use of the word, but also I'm every data manager. So from a distance, I'm desperately trying to get people to send in data capture forms and replies and so on. And actually, I really enjoy that. My previous time in the ERTC and doing a lot of clinical trial work in Bristol has been very well used, I think, in that field. Then we also joined some collaborative UN initiatives with WHO and other UN agencies, because quite often we've all got a bit of input to the same subject. And one of those is with the challenge of cervical cancer, which is obviously hugely high incidence in many of our member states, and very frustrating because it's a cancer which can be prevented or detected early or treated successfully. And sadly, that's not happening in a lot of places. And we've all got a bit of input. So there's that UN AIDS related with HIV control, which obviously is related into this as well. WHO hugely with the work that they do. And so we actually have been on some inception missions together for cervical cancer planning. And actually the picture up in the top right was a very enjoyable mission to Dar es Salaam in December 2017 when it's freezing in Vienna, and we were very, very well looked after in Dar and discussing how we could improve things there. And actually one of the very obvious things was the time it takes for a patient with symptoms to get to care. I think the staff at Ocean Road are doing an amazing job with what they have once the patient is there. But actually, if a patient takes more than 6 months to access care, then everything you do from there is wasted, really. And it's, yeah, they're young women, HIV positive, HPV positive. That cancer is not going to stand still for 6 months. And so actually helping to develop those frameworks into care is just as important as what we do with the radiotherapy. There are also the impact mission reports, which are done here to try and help member states wanting to plan cancer services and therefore put our radiotherapy, which is really our bit of it, if you like, our niche, into the broader context of being more effective in use. And then we maintain many standards and advisory documents on anything to do with nuclear technology, and those are freely available online, and they've got basic training manuals, core curricula, departmental design, suggestions for equipment, quality control, introduction of brachytherapy, transition to newer techniques, and so on. And we maintain and update those. What have I done? Well, we're trying to help redevelop government radiotherapy in Madagascar and Malawi, both from very low-income countries. I spend quite a lot of my life, that's me, with one of the project management officers standing beside a construction site, and that's quite often what I go to do, trying to turn it from being a construction site into a nice department like the top right-hand diagram, which is taken from one of our manuals that you can download online that literally tells you how to build your own radiotherapy centre from scratch. We're also developing, helping to train for new developments. We want training for some new centres in Côte d'Ivoire and Tajikistan. I do a bit of Eastern Europe as well. At a more advanced end, helping to arrange fellowship training, expert missions to do some national training courses in stereotactic radiosurgery in Costa Rica. And pediatric radiotherapy, I think, is a challenge everywhere. Most of the world's children are born in low and middle income countries, and children have the most to gain and the most to lose by poor quality radiotherapy. So we organise, and I believe it should be a subspecialty from the start. So I've organised regional training courses a couple of times in Costa Rica in Spanish. Now, that's what the group of people looking happy in the sun in Costa Rica are doing. And we've also arranged it in Tunisia, actually in English, and another one is going to happen in Bamako in Mali in French this October. And those have been really well received. I think most radiation oncology colleagues I know agree that they really, really want to try whatever your resource to treat the children as well as possible, because they're going to live many years. And I've been running trials on blended learning, so this is in collaboration with ESTRO, seeing how well you can teach contouring by not purely electronic approach. They have an instructor online and they have homework to send in, and we've measured the benefit of doing that. And that's a very happy bunch of people, actually also in Costa Rica. I don't spend all my time in Costa Rica, but they had to go online at 6 a.m. in the morning to do the workshop because they're 2 p.m. European time. But Mongolia had it at 9 at night, and actually that's worse. And then we have trials on hypofractionation. Hypofractionation is obviously, it's better for the patient's economy, but it's obviously better for use of resources as well if hypofractionation is as effective as longer courses. And that's something, that one, the lead there is Soren Benson, and we're really looking at what benefit you get by avoiding accelerated repopulation. And we also have an ambitious trial, SBRT versus TACE for hepatocellular cancer, a big killer around the world, but that's quite a difficult trial to sign up to. Yeah. So what's the biggest challenge? I'm a pessimistic sort of person, but at the end of the day, I do think GDP per capita, a lot of things come down to money. And unfortunately, within that, it's easier to be surprisingly bad than surprisingly good. So you can have a higher GDP and not maintain your services as you should. But it's very difficult to have a very low GDP and maintain a radiotherapy service. And I think probably what I find the hardest in my job is visiting countries and persuading people to focus on revenue and sustainability rather than what can we get now. Because actually often there are very generous donors. There's certainly a lot of people telling you about new and great machines. Manufacturers got their adverts out there. There's a lot of feeling, well, if we can buy that, that's better than type B. But actually people need to look at the sustainability within the country's own GDP. What can you get out of the resource that you can put into this part of healthcare? And I put up these two rather depressing charts that the larger area, I don't know if you can see my cursor, but the larger chart is low-income countries in Africa, and then the bottom right chart is lower middle income. And I've given you blue if you have radiotherapy, grey if you don't. I apologise, I need to take my hand off this cursor. Red if you've had it and lost it. And unfortunately, at the lowest GDP that we can measure, it's clear that we and some other benefactors have said, let's really give them a leg up, help them get going. And many of them had radiotherapy 20 years ago, but haven't been able to sustain it. That isn't necessarily a bad thing. It means that 10 years worth of patients got treatment. I don't think it's all wasted, but it does just show the difficulty of sustaining services in an environment where you can't pay maintenance contracts, you can't save up for the amortization costs and replace equipment, and you can't afford, if you train staff out of the country, they leave, and you haven't been able to start your own local training. It's very clear to me that at the top of that chart, the countries that have managed to sustain services almost entirely are actually the richest in the low income group. If I move to the bottom right chart, this again, GDP rises up the chart, and I've made some of the upper ones green because they've not only sustained it, but they're clearly now sustainable. I don't think, places like Tunisia or Egypt will, or Morocco or Sudan will actually lose it entirely. Sudan has less, but they have managed to expand. And again, it's very clear there's fewer ones. Almost everybody has managed to sustain apart from Congo-Brazzaville, and it's clear why that happened. So that begs the question, how do you persuade people to take a model that they perceive as second rate? I just point out the two pictures I've got there of the team in Mali around their linear accelerator, which is a sole linear accelerator. The problem with that is that I believe it's non-functional probably 3 to 6 months of the year, having a sole LINAC in a low-income country. And that's actually despite a maintenance contract. It's difficult to get the people. The upper one is one of the older cobalts that I've seen in the world. I think that one's 1992, but there's one from 1989 in the same country. And they are still functional. They're actually maintained. There's no maintenance contract, but they're maintained by the doctor, who is the engineer. They're very simple machines, but they are still. And I think that particular one treated 2,800 patients last year. I don't know. I couldn't sit here and say it's good radiotherapy, but it's better than a broken machine, and that's the challenge. But really, the hardest thing is telling people, how do you plan for sustainability within your own resources? And everybody somehow hopes that more resources will come, or that they'll be able to train a really good maintenance engineer themselves who can maintain a LINAC, which the companies don't like. I don't know. It doesn't work. Just finally, how might I do things differently? Just with my career, I'm really glad that I've ended up doing a job in global medicine. I think that actually, if there are trainees out there, consider somehow going to work in a low and middle income country as a junior doctor, training under somebody like Untitled, somebody like Joel, early in your career, because it's the best way to understand being there. You understand, and you also learn what can't really be expressed. But when you're there, you understand about how you have to make do. And I wish I was fluent in a second UN language. You know, I really admire. Yolandi has grown up in a country where they also speak lots of languages. I struggle through in Mali with my French, but I wish I was fluent in at least one language. So if you're tied to your own training in your own scheme, but you have some time in the evenings, please become fluent. It's not easy to set things up for yourself, so prioritize taking a training job and an eventual specialist job in a hospital that has existing global links. It can be very hard to bash your head on that brick wall, so you need a mentor who thinks that your interest is a good thing. I think study cost effectiveness and efficiency models, be very open-minded to what other people in the world are doing, get some understanding of management, and I should have put in training, get a basic training qualification. And then I'm afraid I was a neuro-oncologist, so stereotactic's fine, but really the useful things to know more about would be gynae, including brachytherapy. That's very useful. Breast, head and neck, prostate, everything. And I'd say Astro do fund some people to come to be interns here, so consider being an intern in IEA early. I didn't know anything about IEA. I knew they did secondary standards dosimetry, and that was about it until I found myself working here. So I would encourage you to try and come here for a few months. And it's one aspect. It's not every aspect. The absolute best is actually to go to Ghana, go to Zimbabwe, and actually do some work there and understand how. Okay, thank you.
Okay, thank you, Dr. Hopkins, for joining us from Vienna. So we're hoping to wrap up our prepared comments by about noon, and we have 2 speakers left. We're going to extend this session a little bit longer, just to have time for some discussion and for the audience to ask questions of our panelists. So I'd now like to invite Dr. Lehrer up to the podium. Dr. Lehrer is a medical oncologist, director of the Indiana University Simon Cancer Center, and he's about to finish his own introduction.
Because we're running late, you know, no, I'm sorry to push you around, but I feel so sorry for the rest of you people. So I will go ahead and get started. Yes, so my name is Pat Lehrer. I'm director of the IU Simon Cancer Center. I've been involved with a program in Western Kenya for the past 15 years. And so I'm going to try to quickly go through the highlights of the aspects of it. This program is called AMPATH, which was originally stood for the Academic Model for the Prevention and Treatment of HIV/AIDS. This was a model that started in the late 1980s. It was a partnership between Indiana University and a brand new medical school in Western Kenya, Moi University. This, with the success of their model for HIV, they actually changed the name of this now to the Academic Model Providing Access to Healthcare, looking at population health. And this is an organizational construct which is very, very unique. It's partnership initially between Indiana University and Moy Teaching and Referral Hospital and Moy University School of Medicine, but it created a North American partnership that I'll talk about a little bit. It was not only about taking care of patients with AIDS by giving them drugs, but it was also recognizing some of the economic issues that were facing the patients and the nutritional problems. And so this was a cohesive program that linked together more than just medicine, and it also linked together more than Indiana University. If we look at the partnership, so this is, okay. Basically, we have a number of different North American universities that are involved with this, and it truly is a roundtable. For example, Indiana, if you will, owns Oncology. We're the leader on the North American side, partnering with the Kenyans. University of Toronto owns OB-GYN, and Duke owns cardiology. So all of us actually at a roundtable own a big part of it, and we can all say that AMPATH is ours. What makes AMPATH, I think, very unique and special is that it really is a Kenyan-led program. We are advisors to them. It's multi-institutional, international. There is institutional ownership by the North American institutions in this program, but again, at the end of the day, this is a Kenyan-run program. This is a paper. Ted Trimble is here someplace. Usually he's the tallest man in the room, or he was here. But Ted, when he was directors of the Centers for Global Health, put together a remarkable group of individuals, and they put on a workshop in which the fledgling National Cancer Institute of Kenya worked with the NCI of the United States to put together stakeholders. And this was just published published last year. This is the first time we got everyone involved with cancer together, and this partnership began to inform the government in terms of policy. We got involved with the cancer control strategies, and because of this, actually, much has happened. One of the things that gave me great pleasure was just a couple of years ago now, I was there for a National Cancer Day, and the headline actually was this fact that there was a new national hospital insurance plan which now covered cancer. This would not have happened without the concerted efforts of the NCI of this country with the NCI of their country in recognizing the importance of this. In terms of the challenges, and this happens all across the world, the challenge is workforce capacity. There are far too many cancer patients that don't have the workforce to take care of it. And we have been working on trying to build an infrastructure that includes education of Kenyans, so it's not brain drains. This is not about us supplying all the physicians to go over there. It's really by developing education and developing more Kenyans that can take care of their own patients. There's access to care issues, what we talked about, and this afternoon I'll talk about some of the a program we've done with our Burkitt's lymphoma patients. An aspect that is uniquely difficult in our country, in Kenya, is that they went from a global system to a county-wide system, and so now there's decentralization. So each of these counties or states now are responsible for their own health care. Fortunately, because of the AMPATH program, we've worked around Western Kenya, and we have strong partnerships. But it does mean that some of the poorer resource counties in Kenya are not as likely to be as successful as the other aspect. The other thing that's happening now, and much to my demise, is what's happened here in the States, is that there have been some Kenyans who have been trained now, and there's problems with privatization. So people are coming in, building their own private hospitals, and so the people with money can come to these hospitals to get care, and the impoverished really are not faced with the greatest care or access. The Moy Teaching Referral Hospital is a safety net hospital for about 20 million people in Western Kenya, and it's allowed us actually to do great things. So actually I did it. How do you like it? There's other slides I could have shown, but I chose not to. Thank you.
Okay. Thank you, Dr. Allaire. We're going to move on now to our final speaker, who's going to join us via teleconference, Dr. Andre Elbawi from the WHO. While we're getting him on the screen, Dr. Elbawi is trained as a surgical oncologist in the U.S. and since 2015 has been working at the WHO as a technical officer in the Department for Management of Non-Communicable Diseases, Disability, Violence, and Injury Prevention. I will let him give the rest of his intro if he'd like, and I'll turn the attention toward the screen.
Thanks, Danielle. Really a pleasure to be here, and let me echo the disappointment to not be in the room with so many dear colleagues and friends. Also, congratulations to the organizers, because a conference like this was really totally unheard 15, 20 years ago, and is the future of global oncology. So it is truly an honor to be able to speak with you, and really apologies that I can't be with you in person. I will also try to make the presentation 5 minutes or less, with minimizing the discussion on WHO, because I suspect many of you in the room do understand what WHO is and what is our mandate. But just to orient the larger discussion, the focus is often at headquarters. What we do in Geneva is set the standards for global oncology and global public health more broadly. But in reality, the greatest impact is what happens at the country office. At the country office, WHO has a presence in 149 countries. We work there as the effective CDC or the NCI or the NIH in those countries, giving guidelines, recommendations, and advice on how to build public health capacity. And that really is the greatest asset of WHO. It's the people who have the boots on the ground that are having daily discussions with ministries of health, ministries of finance, about how to improve health services and public health in a country. And really, we should also recognize one of the key functions of WHO is to work with partners. And this is why opportunities like this, to have a global discourse, to present with an esteemed panel as we're doing today, and thanks to Danielle for including me in this panel, really is one of both our privileges and also a unique opportunity to support government. Here's the organogram. I won't even try to go through it, because of course in this slide you may also see in screen upper right, that is IARC. When you combine all of us, we're about 9,000 people strong, of which cancer is less than 5 people. But in reality, we are an organization that functions according to mandates. And recently, the momentum behind cancer has changed, and that is in large part because of a resolution that many of you may have heard about, the Cancer Resolution from 2017, which received strong support from the governments listed in the blue box and beyond. Now, when we talk about what do we try to achieve in cancer health policy, we view it through the lens of universal health coverage. Universal health coverage is defined as ensuring that access to quality care for all when it is needed and without suffering financial hardship. It captures the principle, as many on the panel have said, what is value for money? More practically, for us at WHO, we give technical support to government. Either it's in policy formulation, as we heard, national cancer control plans, setting priorities, defining benefit packages. We also support health system strengthening for cancer, looking at workforce planning, access to medicines, costing, financing strategies, etc. And with our link to IARC, the International Agency for Research on Cancer, which is a specialized cancer research agency of WHO, we also look at surveillance data to better understand what is the disease burden and what are the important carcinogens. Now, when we develop this technical guidance, it in fact is most relevant when it's applied in country. So as I mentioned, we have a presence in every country, but in fact focus on 2 priority areas in cancer. As Kirsten nicely mentioned, cervical cancer is a priority, and we've also recently launched an initiative on childhood cancer. Recognizing that countries ask us often to do more, we do comprehensive reviews, as Kirsten mentioned, also known as impact reviews, which we're very pleased to do with IAEA and with IARC. And what brings me here to Saudi Arabia, which has kept me from being with you in US, which is a pity, but we often get called to government to specifically speak about an element of a cancer program, whether it's treatment guidelines, access to medicines, the essential medicines list, procurement mechanisms, workforce planning, or a cancer screening program. We spend about a third of our time in country giving technical support in one of these or in broader cancer programs. So what are the challenges? What are the opportunities? As you can imagine, WHO is supposed to be the public health agency for the world. That sounds like an impossible task, and in many ways it is. We do so with a limited staff and a very limited budget. If you compare the WHO's budget to the public health agencies in the US, we have about 1/20th the budget that the public health agencies in the US have, and we're supposed to do it for the entire world. And then, of course, let us be very frank with ourselves. In public health, we always have to ask, are we really making an impact on the ground? And that is a daily challenge that we encounter. So what are the opportunities? What have we done to address some of these challenges? Well, our current Director General has been explicit about what our objectives are in the next 5 years. It's known as the triple billion goal. We also set country and regional specific priorities and targets. To address the limited staff and budget, This is, again, why partnerships are so important for us. How can we utilize our networks and in-kind support to build capacity in country? And how can we engage stakeholders beyond the WHO network to support implementation? To address this issue of the policy versus practice divide, how can we translate policies into improved outcomes? Well, really the first point is we do so according to what the government needs and what they ask us to do. The WHO is a member state organization, which means governments tell us how to do what we do and with how much money we're supposed to do what we do. So all of our goals and objectives are oriented around what the government tells us are the specific priorities. And our function as WHO is to act as facilitators, catalysts, and conveners. What would I have done differently? This is a great question that Danielle asked us to comment on. It is not an easy one. On both a personal and an organizational perspective, I think comments can be made. On a personal level, in fact, these are three of many things that I could have done differently. First and foremost, I do want to say that it is an absolute privilege to be in this community, because I do think those of us in global oncology have a unique opportunity to touch lives outside of our communities, and that is perhaps one of the greatest privileges in our life. So all my responsibilities I frame through the privilege of being at the WHO and working in our community. But of course, it is important for me on a more personal level to think about when I come to a country like this to give technical or policy advice, is this better use of my time than being in country where, as Kirsten said, perhaps I could be a cancer surgeon sitting side by side with a trainee or a surgeon in country? And frankly, this is something I struggle every day with, and there's no simple answer to that. As Kirsten mentioned, there's also timing. When to do policy work, do you do it earlier in your career or later? And this, again, is something for which there's no perfect answer. In general, I think later in career is more compelling, but there is something to be said doing it earlier when travel may be easier and when the commitment to the significant demands in the policy realm you may be able to respond to with greater speed. And then, of course, I think we all have a unique platform. I'm not on Twitter, I'm not on Facebook. I do believe in the value of advocacy, and I absolutely believe in advocacy with the passion. This is something that really, on a more personal level, I think we should approach our work with a passion, and every day I try to wake up with more passion than I had the day before. From a WHO perspective, of course, budget and efficiency is a major concern. What could WHO do differently? We are looking at an expanded business model with increased funding and increased capacity. We are looking at our strategic presence so that, in fact, we're not just responding to problems, but in fact identifying issues that arise or that may arise in a community and anticipate them more proactively. And also to engage market experts in other domains, market analyses, economics, communications. We're often one step behind. I think the last presenter who raised the issue of private sector as one competitor, that's maybe true in clinical services, but it's absolutely true as pertains to NCD prevention and control. We're always one step behind tobacco, one step behind the other risk factors, which we know are a serious threat to public health. Before closing, just to say, and this is one extra slide, I'm sorry to continue, but there is work, as Kristen said, that you can do with UN agencies. And in fact, this is something I did not realize until maybe 3 years before joining WHO. There are unique opportunities to engage with WHO at the country level. So if you are in fact working in a country, please feel free to reach out to the WHO country office. You may be surprised that they will be very pleased to hear from you and to work with you, particularly if you have an existing engagement with the ministry more formally. And when you do, if you can link your activities to the cancer resolution, which in fact is a mandate and a responsibility for WHO and for partners to implement, that will increase the likelihood that your dialogue with the WHO country office and with the ministry will be well received. The other opportunities for engagement with WHO, we're always looking for people who are doing interesting research and reviews. Danielle can mention an interesting one that she is doing now that is very informative to our work. And these are types of technical work that we welcome and appreciate. And the last is employment. So in fact, at WHO, we look also for interns, but in the next year, there will likely be as many as 8 postings for positions in cancer. In the past 15 years, there was 2. So for us to have 8 this year is a major, major opportunity. each of you in the room actually meet the criteria of who we are looking for. So please keep your ears close to the ground, and we'll be sure to share that information as soon as it becomes available. And the last slide is this. This is a gentleman I met on the street of Chicago. He was about 2 blocks outside ASCO, and I find this to be very indicative of some of the challenges in cancer. Because in fact, the service that we can do for our communities can just be outside our own door. So I'll leave the photo up for reflection, and thank you again for the opportunity to share some perspective.
So I think that was a really good way to end. Thank you very much, Andre, for joining us from Geneva. I'd like to just quickly invite all of our speakers who are here to just come on up for a moment. We're going to have about 15 minutes for questions and discussion, just to have an opportunity. Don't want to hold you back too long from lunch. So I'd like to just start the conversation. The goal of this session was really to present information and a bit of a perspective on career paths within global oncology that are outside of traditional clinical work or outside of traditional research, and to give a sense about how some of the clinical programs and research actually influence policy. And we heard about policy at the international level, the level of the specific hospitals or in country, and I wondered if our speakers could comment a little bit about whether they see health policy as something that is truly global or something that needs to be addressed at more of the local or regional levels, and what the ability of external people working at other organizations really have to influence policy in country. So if anyone would like to start.
I think that it should be a two-pronged approach. It cannot be wholly international. I say this because, like the quality of data, for instance, our cancer registries, GlobalCan 2012 versus GlobalCan 2018, the quality of the data that WHO churns out is dependent on country data. If the country data is not accurate, WHO data will also not be accurate. For instance, in Ghana, on GlobalCan 2018, lip and oral cancers have been given very high figures, but I sit in the clinic and we do a combined clinic with the head and neck people, so surgeons. So it's not as if it's only radiation oncology, and we hardly see lip and oral cavity. And when one of the WHO guys visited us, Max Parkins, we told him, and if you compare Ghana statistics on lip and oral cavity 2020, 2018, it's gone down considerably. See, so it's, how well, we need the international input, but then we have to do well locally in our statistics to enable planning.
Mm-hmm.
I think all policy levels are very important, and what really makes a difference is how they interrelate and how all the pertinent aspects are taken care of, especially, the regional variations, the regional variations, and, the understanding of, the factors that can influence the implementation of certain policies in certain regions. And talking from Africa, I know that sometimes there are policies, like from WHO, IAEA, that are meant to be for Africa as a continent, but really Africa as a continent is very large, and there are variations between countries, between the sub-regions, and even just the disease patterns are different, and let alone the socio-cultural implications that come with that. So it's an interplay that really needs a lot of consideration and a lot of engagement of all the various stakeholders to make sure that whatever comes up is implementable and can actually make a difference to the lives of people.
I was going to, geez. I was going to say. One of the aspects that I think comes up for the ICEC is that many of the participants here are young people who are trying to figure out a career in global health. And I think one of the lessons is, for me, is that health policy, if you will, if you know one country, if you pick one African country, you know one country. There's a uniqueness there. The difference between politics here and in Canada are so dramatically different. And so I think what was brought up by Norm in terms of this reciprocal innovation, I think it's really important to think that we aren't the brilliant people here going over there to save these people there. They have dealt with inequality, racial prejudice, access to care, and many of the solutions that they have actually will make our United States healthcare system better. And we ought to listen to them. One example in Kenya is that there are not enough healthcare workers, and so we use community healthcare workers that go into the villages, to go home to home, to talk to these villagers about diabetes, HIV screening, and other aspects. We have now brought that back to Indiana, where we use community healthcare workers in the urban parts of the city where many of the poor don't come to the hospital. We're going out to the rural parts of the state, going home to home, and talking about tobacco, vaccinations, obesity, and getting them pulled into that. We have the notion of doing HIV testing. Actually, we now go home to home in Kenya, and we have tablets in which we can actually get information. We have better tracking in Kenya of patients there than we do in Indiana. So I think the lesson is that what we can do is take things from them and have a roundtable of a discussion. But recognize that if we're going to be policy, we need them in their country, the Kenyans or the Ghanans or the Ugandans, to do the work with their politicians. We can help guide them. But in turn, we need to listen. How did they get it to work in their country? Prevention, screening, early detection is far more important. We got it wrong in this country. We put more emphasis on treatment. And in those countries, we can actually do it better and do it the way we ought to be doing it here.
Great, thank you. If any of our other panelists would like to comment, otherwise I can, yep, Kristen. Thank you.
Well, I was just going to say, thinking about the fact that we're talking to young people who are interested in this, you should learn to be an advocate. That's one of the domains and skills of training to be a healthcare professional, is actually learning to advocate for your patients, and then with a hospital board to introduce a new specialty. And at a higher level, the people I most admire are people who can advocate to ministers and governments and make them allocate resources. And I suspect that at times both Ntokozo and Joel have had to talk with their governments, persuade them to allocate limited resources towards their centres. I really admire Kandila Shimpi in Zambia, who helped set up the first unit there. And when I said to him, how do you advocate? He said, I talk to the civil servants. I don't talk to the ministers because they change all the time. But once they get in, they turn around to the civil servants and say, oh, what do we do about cancer? And they say, oh, you listen to the Shimpi, he's a good guy. So he said there's a few key things you have to learn how you can influence and how you can influence policy. But I don't know how you do it in each country. You have to get government on side. And I think that you recognise that non-communicable disease is the challenge of now. But the people who can do it and push their case, very impressive.
Right, thank you. I'd also like to open it up if anyone in the audience has questions that they would like to direct either to the panel as a whole or to specific panel members. Yep, please.
Thank you so much. My name is Fidel Rubagumi. I'm from Rwanda. My question is specifically to Yanni and Drovu. I'm probably stepping into their shoes. And when you finish your training and go back to your country, you find that you're pulled to all directions: policy, research, clinical work, and sometimes politics. How do you manage this as a young oncologist?
That's a very good question. It's hard. It's hard. But when I was a newly qualified radiation oncologist, it was very difficult to actually get to prioritize what to do. And so I found myself, I just overworked, which is why I was, I think there's something maybe, there's something about my voice that doesn't pick my. I tried to prioritize probably everything, but obviously it is impossible to do that. And then at the end of the day, you just have to take one step at a time. For me, it was prioritizing of clinical work, and because that is really the patient care that you want the patients to get the care. And then the other things came secondary. But then you then realize again that you can't work alone, which is what I mentioned earlier. So developing human resource or promoting the development of human resource is very, very important, because you could do it when you are younger on your own, but as you go on, you actually need other people to come alongside. You then find that you have more time then for other things, such as research and policy development. But it doesn't mean that those things you can actually set them aside completely, because the example that I gave of prioritizing, the healthcare facility needs, prioritizing the needs for drugs, you might have to start doing it from the first day that you are on the job. So it's a unique situation, which is peculiar to particularly African countries, and in perhaps maybe all low to middle income countries might experience that, but in the African setting, where half of the countries don't have radiotherapy facilities, and somebody has got to get up and do it and make sure that facilities become there, it's going to be a problem for long. But now, that's where now, at least now we're in this room, we're all talking and we are together. So perhaps that can be an avenue where other people who have to start now don't have to go through the flooding with responsibilities that maybe some of us in the past have had to face, but use the resources that are available in a forum like this to make life more manageable.
Perhaps more time on the golf course then.
Yes.
Yes, please, at the back.
Yeah, I thought that I would say.
Thank the panelists for sharing their perspectives. And I heard the young oncologist in the audience was asking some questions. So taking a lead from that, I just want to ask any panelist, what are the initiatives which are integrated during the training program, not only for global health policy education and also national oncology policy education?
Most radiation oncology training programs are limited to the subject. You do not learn much about global oncology. But over time, for instance, I did, NCI has a 8-week program on cancer epidemiology, for instance, and I participated some years back. It influenced my thoughts. Back to your question. You train, and at the time that I trained, I think there were four of my seniors. And when we finished training, at the time that I was returning back to Ghana, none of them had returned. And I was the youngest, so I get back and you realize that, should I stay or should I go back? Me, for instance, at the time I had written the USMLE, so I said, why should I stay or go back? But you realize that nobody can improve your country for you. You have to do it yourself. Okay? So it's a decision that you make, and sometimes people will wonder, are you crazy? Why do you stay around when you have other opportunities? But you have a lot of satisfaction in improving your own system. and you start practicing, and you see the spectrum of diseases. All your patients are coming stage 3B, cervix, head and neck cancers, very advanced. Then you ask yourself, for how long am I going to do this? What am I achieving? When your case distribution is about 70 palliation and only 30% for cure. Is this going to be like that for the rest of my life? That is when you decide that you have to influence policy. That is the only way that you can achieve something. So then you learn, you start talking to politicians, you start visiting ministers' office. Over time, they get to know you. You make presentations. So, for instance, the national strategy on cancer control, you suddenly realize that no one is better positioned than you, because you have a balanced view from your external connections and your training. And most of the public health physicians in our part of the world, they know more of infectious disease. They don't know much about oncology. So you suddenly realize that you have to champion this. And you master courage and you get things done. Realizing that if you don't, and also you invest in training, because you know at some point in time, if there aren't many of you, everything will collapse. Then what is your legacy? So then you also write programs. Ghana, for instance, we have the Ghana College of Physicians and Surgeons. So all the training programs, surgery, and all the other disciplines fall under that. So you become faculty of the college, and you get things done over time. So it only gets better over time as you continue.
Thank you. Yeah, Kristen. Thank you.
I just have a general question for anyone. So my question is really, there are a lot of great grassroots programs and a lot of interventions and things that are being done out in the community. How do you all recommend that people bring those successful programs or interventions that have been done to the attention of policymakers when it hasn't been done from a top-down approach, it's really been done from the bottom-up approach?
Well, my 2 cents, I'll just throw this in. Over my experience in my lifetime in terms of even here in the States, you've got to get a community together. You know, if you're building the breast program, it can't just be one person who's doing breast. You got to have a surgeon, you have a radiation, you guys get together and you realize it's not any basic scientist. So you've got to figure out a way to create these communities, these little, a culture of people that may be volunteers in the community, but in your own center. But with this community, then the power goes on. There's a lot of people who go to Africa on mission trips, you know, so they go over there, and it's like putting your finger in a bucket of water and you pull it out and there's nothing that's changed. So you've got to create a community that's on ground, and if you can get your, you know, what we've done at IU, at any one point in time, there's probably 20 faculty members that are on ground in Eldoret. It's a safe place, so that our medical students love to go there for rotations because they're safe, there's other faculty there, and they're interacting with other people. But because of this community that has been built, we have Chite Aswara, who now, we have people who want to stay there in Kenya because they aren't alone. I can't imagine, you know, coming from Somalia and coming to the United States, getting trained in radiation oncology, and then going back to Somalia. You know, because there's nothing there. So you've got to create a home for them. That's my thoughts.
Great. So we're going to wrap up now. Just before we do, I'll just turn to Andre and Yolanda and just check in to see if they're like to add anything to what's been said. And if not, I'm sure they'd be happy to, I think all of our panelists would be happy to continue the conversation over email or over lunch, depending on where you're located. Anything further from anyone on the panel?
No, just to briefly mention, I think the panelists echoed many of the sentiments that I would have stated. The one point just to reinforce about how to engage and achieve a sustainable program is ask the ministry or look within the cancer plan as the panelists raised, governments have strategies for cancer prevention and control. If you can identify where within the government's cancer agenda you can fit, then you will find most ministries will be so pleased to have you on board. So early dialogue with ministry is often better. But otherwise, the comments about teamwork are absolutely critical, broad dialogue, and I really did appreciate the other panelists' points. So nothing more to add. Thank you for the opportunity. Please do contact if there's anything more you can do.
Great, thank you very much. And thank you to all of our panelists. Give a round of applause. And I think, would you like to take it?
A couple of things. Again, thank you to all of our panelists, both near and far, and thank you to Danielle for moderating. We will move on to lunch. We plan to start our next panel on schedule at 1 o'clock. If you need to bring your lunch into the room, you are welcome to do so. The other thing that we ask is that we really want to seek your feedback because we hope that this is the inaugural meeting and that we have many more to come, and we just want to continue to improve upon what we're doing here today. So please fill out your feedback forms. They're available out front and online. So we'll dismiss everybody to lunch and see you here at 1 o'clock on the dot.